Good morning.
Good morning.
Let's pull up EP conference. All right. So just see, do we have enough people? I think we can get moving. Okay. So here's our so this is a child who had an interrupted aortic arch, VSD repair, newborn, couple of days old. And this is the monitor bank. I want to acknowledge Pediatric Cardiology blog. It's an old site from a former fellow in Texas who posted a lot of interesting tracings. So this is a tracing from the monitor. Why don't we go to Tarek to say, what do you think is going on here? And what do you think, what are some of our options to address this?
Good morning, Dr. Bass. So it's obviously a tachycardia. I don't think I see, trying to see in the tracing like P waves, but it doesn't look that way. And then given the history of the BSD, one thing I'll be concerned of is going to be jet. So, sorry.
No, I'm sorry. I didn't mean to interrupt you.
Yeah, so then two things will help us then with that, looking at the CVP tracing, I think it will be fair to say it looks like Canon A waves, probably the middle ones.
Mm-hmm.
And then also the from the Artland tracing, there's no gradient given the interrupted aortic arch repair, but there's dampening of the blood pressure. So I guess like one thing, how many hours out of the surgery or how many days is the patient to know the approach?
So let's just, so very, very nice analysis, Tarek. So the first thing to note is, just as you said, the CVP, most important observation here is how irregular it is, right? As you said, they're intermittent, what look like Canon A waves, right? Normally when we see the CVP in somebody who's in sinus rhythm, we'll see very consistent pattern from beat to beat to beat. This is obviously very inconsistent. And that really is the key to this tracing. You know, as we've discussed many times, you don't want to make any diagnoses in people for arrhythmias based on a single lead of the ECG. And the reason that I've included this tracing today is because you really can't tell from the EKG what the rhythm is. We can see that it is fast. We can certainly accept that the heart rate is 225, but you can't really tell from this monitor tracing whether or not there are P waves before every QRS or after, or if there's ventriculoatrial dissociation. So from the tracing alone, you can't tell. So this is an example of how it's useful to use all the information at the bedside in making a diagnosis. And in this case, we see that the CVP is very, very irregular. So oftentimes when I'm called to a bedside and people are asking me whether I think somebody is in jet, the first thing I'll do is just look up at the CVP tracing, because in this case, I think it sort of tells the whole story that there's definitely an irregularity between atrial and ventricular contraction. Now, we can't tell from this whether the patient is in some kind of tachycardia like jet, or if this could be VT, right? You could have VT with ventriculoatrial dissociation or intermittent association. So you really would need a 12 lead in order to compare it to the baseline and know if the QRS morphology is the same or different. The other thing is that on the blood pressure monitor, we see a lot of variability in the blood pressure. again, consistent with different degrees of filling of the ventricle with different blood pressures. So this is all suggestive of, probably jet, as you said, but it could be VT as well. It could be either really, but probably is jet. So this tracing or this screenshot of the monitor was from the day of surgery. So let's say it was obtained at 8 p.m. and the operation was performed at 3 p.m. or finished at, or let's say 2 p.m. And we see here that the patient's temperature is 35.7 degrees. So what would you next do, Tarek? So you're at the bedside and they're asking for your expert consultation.
So as you mentioned, Dr. Past, then assuming as is jet, we made the diagnosis with the EKG or atrial EKG, then I think because the temperature is 35.7, it may take some time to really cool the patient to 35, then maybe procainamide is not going to be the best option as like if we want to start. Yeah.
Why do you say that procainamide? First of all, if you're what is 35.7 cold or normothermic?
No, it's cold, but for
So,
procainamide, we have to go to 35, no?
well, yes, no question. In an ideal world, you'd like to be 35 when you give the proc, but 35.7, you said it's going to take a long time. I would argue that if you put this child on a cooling blanket, you could probably, especially a newborn, you could probably get the temperature down to 35 in 10 minutes on a cooling blanket. Okay, so you're at 35. Now, why did you say, though, that you thought proc would not be effective in this case?
No, it will. I think it will, but just because of the cooling, that's why I was gonna suggest maybe amiodarone and starting with a very small dose, 5 mg per kg over 2 hours. And
yeah, you could definitely do that. You could give amiodarone. Actually, I just took the first part of my board recertification, and one of the questions was about management of jet, and the only answer that made sense involved amiodarone. So yes, amiodarone could be a great first line, but or you could give procainamide. And so if you gave amio, I agree, I would give 5 per kilo. We've talked many times about the risk for cardiovascular collapse in an infant, so you'd want to give it slowly and keep a very close eye on the infant while you're delivering this medication. But okay, so you and if you were going to give procainamide, how much would you give of that, Tarek?
Yeah, so if we give procainamide, so I'll go with also 5 milligram per kilo bolus over 15 minutes, watching also the blood pressure, and then we have to if the patient does not respond, then we can repeat the same dose, and then also we prepare the drip as well.
What is the most common complication of the use of procainamide? I think you already said it, but I just want to.
The hypotension.
Right, and what's the mechanism for the hypotension? Is it a primary cardiac thing, or is it vasodilation?
Vasodilation.
Yeah, it causes vasodilation. But the treatment for that is typically volume. If you read in a textbook how much procainamide one ought to give, you'll see that it should be between 10 and 20 per kilo. And that is sort of the standard thing that people do. But what I've learned is that actually giving it in 5 per kilo boluses, the people who use that routinely will say that markedly reduces the degree of hypotension that is observed. But it would not be uncommon to need 3 boluses of 5 per kilo to get control. Okay, and then what dose would you put the child on as a continuous infusion?
So I think we'll start, just from seeing what you've recommended before, starting low at 15 microgram per kilo per minute, and then we have the option to titrate up to 20.
Actually, 20 is the starting dose. I would always start at 20. So it's 20 to 40. 20 to 40 mics is usually the starting dose is 20. All right, so you could give either procainamide or you could give amiodarone. And once you see that the rhythm is slower, you could then potentially apace the patient. Now, some people would try apacing even before you do all the things you've just described, but some people would even try apacing at, say, 230 or 235 on the theory that AV synchrony may be superior even at such a fast rate versus this junctional rhythm. In my personal experience, when the rate is this fast, I would not hold out a lot of hope that apacing is going to improve the patient. In fact, to pace at 230 or 235 might actually be very hemodynamically embarrassing. So if you're going to even try that, you need to be very carefully monitoring the blood pressure and the CVP and the perfusion, and chances are you'll know the answer to whether it's better or worse almost immediately. So, and most of the time it's more effective, I think, to use these medical maneuvers that you're describing and then see what happens. So let's say instead of using probe, we used amiodarone because that's used very commonly. So you give your 5 per kilo bolus, and how much would you put the patient on as a continuous infusion following that, Tarek?
So following that, I think we can start at 5 also per minute.
I would probably start at 10.
Okay.
10 milligrams per kilogram per day, right?
Per day. Okay.
And if the child is still tachycardic, what could you do at that point?
So yeah, so I think at that point we can give calcium and then increase the dose of the amiodarone.
Yeah, I mean, normally we would give another dose of amio, right? Another bolus. You can give another 5 per kilo over an hour or two and see if that that does it. Most of the time, by the time you've given a second bolus, you'll get some degree of control of the arrhythmia. I'll tell you an interesting thing. When I started my career, when I was in training, I was taught basically what we've just described, either using procainamide or amiodarone was starting to be used for this indication. But one of the things that a lot of older cardiologists believed was that digoxin was effective for the treatment of JET. And I had never heard that. I had never seen that. I had never read that. And let me be very clear, to my knowledge, there's no evidence at all that digoxin is useful for this. However, when I started my career, I knew that the older cardiologists would look down upon me if I had not also started digoxin. So I virtually in every case for like the first 3 or 4 years of my career put patients on digoxin because there was this almost religious belief that digoxin would also be effective. I would do all the things that you're describing, but I would also add digoxin just so that nobody would cast an eye on me that I was a cretin for not using digoxin, even though I think we would all agree that nobody uses digoxin for this anymore. Another belief at that time, since we're talking about people with VSDs closed, was that all tetralogy patients needed to be on digoxin indefinitely for the rest of their lives. That something about having a right bundle branch block made them needing this. And so it was very common to see like 15 or 20-year-old tetralogy patients who had been on digoxin their entire life. That was a very, very strongly held belief for a long time that also faded away in the last 20 to 30 years. So anyway, okay, very good. So I think the main point of this tracing is that we can sometimes make diagnoses or at least have an idea based on indirect evidence, such as the CVP and the blood pressure in this case. Also that even without looking at the tracing, right, if I told you that a child with an interrupted arch VSD on post-op day 0 was tachycardic to 225, right, I think you have to, in your mind, it's important to understand what can happen or the differential diagnosis, and then use the information in front of you to confirm or refute what you believe is the case. Okay. All right. So this is a 12-year-old following a pulmonary valve replacement, and we're postoperative day 4. So the question is, what are we looking at, and what should we do about this? I'm going to ask Dr. Candon what she thinks.
All right, so it looks like well, it looks very slow. And it looks like we may have had a dropped beat somewhere between the first and second QRS complexes.
What are these
Uh,
babies?
They look like P waves.
Mhm.
So some kind of heart block.
Right.
If we're having P waves that are not conducted to QRS complexes.
So is it first degree heart block?
No, it's higher degree than that. And there's no consistency in the R to R interval. So I would say third degree heart block.
Well, it's hard to tell,
Okay.
right? Because, generally speaking, when people are in heart block, you see a pretty consistent R to R interval. We've talked
Oh,
about
okay.
how, however, and so you could argue that maybe the irregularity from this beat to this beat maybe suggests some conduction, but it's also possible that this is just a ventricular escape beat of some sort, right? It's clearly not the same as the other beats. So I think you're probably right that this is complete heart block. You would want to watch it a little longer, but probably you would not want to watch it any longer because I'm sure the patient is not hemodynamically very stable when left like this.
Right.
Okay, so this is a tracing you've obtained after you turned off the temporary pacemaker.
Mhm.
The father of the patient is standing right next to you and says,
Mhm.
Dr. Kanzen, what do you think? Are we ready to go home? Is there anything we need to do? Is this going to get
Right.
better?
So I would say that the patient needs to be paced. So I'm guessing they have epicardial pacemakers. I mean, pacemaker wires from the surgery,
Mhm.
and I would pace them.
Okay.
And I don't.
So you're pacing them now, and
Oh yeah.
patient wakes up from the syncopal episode you've just induced during your check.
Yeah.
Says, "Oh, thank you very much. I feel a lot better now." So now the father wants to know, like, what's the chances that we're going to
Yeah.
need a permanent pacemaker?
I would say that it's a little too early to say. I would wait until post-op day, maybe 7 to 9. If they're still requiring pacing at that point, then it's, I would say, likely that the patient will need a permanent pacemaker, because if they're requiring pacing after post-op day, like 9, they're at a higher risk of, like, is it Stokes-Adams attacks
Mhm.
and ventricular arrhythmia. So
That's
it's too early to say.
It's exactly right. And so this actually comes from, I guess now a 25-year-old paper on only 32 patients from Boston Children's. But basically, this is where the original idea of 9 days came from, showing that basically in the 32 patients by postoperative day 9, 31 of the 32 that recovered by 9 days. And after that, there was, so these are all the people who recovered and when they recovered. And basically what it shows is that basically by about day 9 or 10, it's exceedingly rare that people will develop conduction beyond that time period. There is a rare patient, here's one that recovered on postoperative day 21. Interestingly enough, this curve, this study was basically redone, as is always the case in medicine. People just, if a study is old enough, people repeat it. So it was redone using an administrative database from the University of California in San Francisco. And the graph that they created based on thousands of patients is virtually identical to this original paper, which only had like 55 patients in it. But the bottom line is this is where we first came up with the notion that 9 days was about right. After 9 days, it was a very unusual, like a 1 in 32 chance that it was going to recover beyond that. So that's exactly right. We would probably say to the family that we shouldn't count our chickens, that there's still a chance that the rhythm will recover, that the AV node and his Purkinje system will recover. But obviously, when we're at 4 days, we we're already lower in our chances or our statistical likelihood of it recovering. And where do you think the block is typipally, Tulsi, in a surgically induced heart block? Is it at the level of the AV node or in the His-Purkinje system most of the time?
His-Purkinje system.
That's exactly right. It's usually lower down and more dangerous because of the less likelihood. Not only is it lower and less likely to recover, but the escape rate will be slower. Okay, so this is a tracing from a 12-year-old who has a really unclear tracing and Emery-Dreifuss muscular dystrophy. So my question to you is, what is the diagnosis and how would you treat this? So why don't we go to Dr. Bebbia? What do you think?
Good morning. So,
I apologize for the kind of crappy tracing.
it's okay. So what I see here is I don't quite see the P waves before each QRS. I see T waves after the QRSs and some deflections that could be retrograde P waves, but I'm not sure about that. I wonder if this muscular dystrophy is associated with some arrhythmias that unfortunately I'm not.
It is. Do you know
sure.
anything about Emery-Dreifuss muscular dystrophy and arrhythmia in general? Somewhat obscure question, so no discredit if you don't know the answer, but it is an important thing to remember.
Yeah, I mean, I
just
just know that it's a muscular dystrophy. That's
yeah.
all.
So all muscular dystrophies, right, are theoretically associated with cardiomyopathy, but Emery-Dreifuss muscular dystrophy is actually, you're right, Sergey, that it's very hard to see any P waves, and the reason for that is there are in fact no P waves. This patient has a very classic finding of Emery-Dreifuss, which is atrial standstill. Atrial standstill is a rare condition, and when patients have it, they literally have very little atrial activity. And the natural history for Emery-Dreifuss patients with muscular dystrophy is to eventually develop atrial standstill. Interestingly, despite the fact that, and when you do, by the way, a 3D electroanatomical map, you basically identify scar throughout the atrium, and there are beautiful pictures. If you happen to listen to my podcast about 3 weeks ago, we talked about atrial standstill, and there's some nice images, and the link is in the show notes to that podcast. But there are some beautiful pictures where they did electroanatomical mapping and identified in patients with atrial standstill basically no atrial activity, scarification of essentially the entire atrium, or sometimes they may identify a single little pocket of area which has active atrial myocardia, but basically the entire rest of it is fibrosed or has no activity. The interesting thing about it is before they develop complete atrial standstill, they actually are at risk for atrial tachycardias. But we rarely will recommend doing any invasive treatment like, for example, EAT or a flutter ablation, because most of the time the natural history is to eventually degenerate to atrial standstill. And one of the observations of this paper that we reviewed for people who have atrial standstill is that they need to be on anticoagulation, and it needs to be something like a NOAC or a DOAC or warfarin, because the risk for stroke is very high. It's like 30% in the setting of atrial standstill. Even interestingly, this particular form of muscular dystrophy often have preserved systolic function. So even with normal systolic function, when you have essentially atrial standstill with no atrial activity, your risk for a thrombus is very, very high. Risk for stroke is very high. And so you would want to treat someone like that. Now, the other question is, how do you pace these patients, or should they be paced? So if the ventricular rate is adequate, you can leave it alone temporarily. But what typically happens is, just like patients who have heart block, their escape rate, their junctional or ventricular escape rate gets slower and slower. And one of the important points of this paper, which was a series of about 20 patients who had atrial standstill, was that essentially it takes hours to find a spot to pace the atrium. And only a very small percentage of the 20 patients, I think only like 3 or 4, were they able acutely to get an atrial wire in that actually captured. And like 3 out of the 4 who they did that in eventually lost capture. So I would conclude from that that probably just ventricular pacing is all that probably should be done, except in the rare patient who has enough atrial myocardium to have consistent capture. Probably if you're going to undertake putting an atrial wire in these patients, you should do an electroanatomical map just to identify an area of myocardium where you can actually capture at all, because most of the atrium is quiescent and is not paceable. The other worrisome finding of this particular form of muscular dystrophy is that they are at risk for sudden death. And so, for example, Josie and I follow a family of children who have this condition, who are paced in the ventricle, VVI, doing very, very well. But I'm always worried about the possibility that they might have a ventricular arrhythmia. And so we surveil them very closely, looking at the tracings from their downloads and also occasionally performing Zio patches or Holters to be sure that we're not identifying any indolent ventricular arrhythmia in these patients. So anyway, interesting, a rare, but you may see this someday in your career, but atrial standstill has to be anticoagulated. Let me just move on for a second.
Thank you.
Sure. All righty. This is a 1-year-old status post mitral valve replacement with postoperative heart block. And the temporary pacemaker is programmed DDD 110 to 180, and the patient is febrile. And why does the heart rate trend look like this? So why don't we go to David Barris? What do you think, Dave?
So right now, we see that there's these two spikes in the heart rate, and then it drops all the way down to your pacemaker minimum rate.
Right.
So we know that during the fever, the atrial rate is going to go higher, and then it gets all the way up to our it goes up all the way to our max rate of 180, and then all of a sudden we have a rapid drop in rate to our minimum rate. So I'm wondering if the pacemaker is no longer sensing the P's anymore because it's within the P-varb once it got high enough.
Yeah, I mean, basically that's very, very good, Dave. What this is basically sometimes what they call upper rate behavior. So when the atrial rate exceeds the tracking rate, you get what sometimes people also refer to as pacemaker wanky-bach. But essentially what happens is that if the rate gets fast enough, you could drop very precipitously, because just as you alluded to, the P waves may fall into a refractory period that can't be sensed by the device because it is not programmed to track rates above the rate that you've programmed. And as a result, the rate will fall very precipitously. And every once in a while, when patients are being evaluated, and you not uncommonly see something like this or a tracing like this on a treadmill test or on a bike ergometer test for stress test. And I would say at least twice a year, I'll get a call from the stress lab that somebody who's having a stress test, usually like a Fontan patient who's having like a surveillance stress, will do something like this as their sinus rate rises. And I'll be asked to reprogram the pacemaker to track a little better higher rates like atrial sinus tachycardia or things like this. So yeah, that's what that is. So what we could do here is we could first of all, you must raise the tracking rate faster than 180. And then you also have to be, now in the bedside pacemakers, the P-varp and all of that all those other timing mechanisms are going to be automatically adjusted downward as you increase the tracking rate. Interestingly, on permanent pacemakers, they do not change those. So you can program somebody through their permanent pacemaker 110 to 180. But if the total atrial refractory period, which remember is the AV interval plus the PVARP, if that does not allow tracking to the upper rate limit, it won't track to that limit, even if you program it that way. So you have to be, we have to be more sophisticated when we're programming permanent pacemakers. But at the bedside, because it's expected that an intensivist may not know all those little fine details of programming of pacemakers, as you get faster in the upper tracking rate, the device will automatically shorten other intervals, not the AV interval, but the PVARPs, to allow for continued tracking at faster rates. But that's what that is. So presumably on the second part, when it goes up, paradoxically, the atrial rate has fallen, allowing for one-to-one conduction. And when patients have this happen with their permanent pacemaker, they describe a feeling of, shall we say, hitting the wall, typically with exercise and things. I used to have a patient who was a very competitive soccer player in high school. He was one of the better players in the state of New Jersey, and his father showed me how this happened to him, even though I had him programmed up to 180, and he's one of the few patients who I had to reprogram up to 200 in order to track him so that he could continue to play at a high level, because he had a congenital heart block, even at faster sinus rates. So, and I think with that, we'll stop for the morning. Appreciate everybody joining. Hope that was useful, and I will see you on Thursday for angio review. Okay.
Thank you, Dr. Bass.
All righty, guys.
Thank you.
Take care. Have a great day.